Dr. Christ. Dr. Christ will be speaking on amputation versus limb sparing surgery. Dr. Christ is an orthopedic oncologist who specializes in the treatment of both benign and malignant tumors and related conditions of the musculoskeletal system. He has a special interest in limb salvage and reconstructive techniques following treatments of bone tumors. And now I'll pass it over to Dr. Christ.
Hey, everybody. I just want to say thank you so much for inviting me to come speak. One technical detail, I'm having a really hard time pulling up my slides. I was wondering if it's possible for somebody else to show slides and I can go through them. I don't know if that's doable.
Yes, that should be doable. Gail, do you have these slides?
You're gonna have to give me a minute, sorry.
Yeah, I know. Of course, I'm actually in the hospital today, and for whatever reason, the things are not technically going as planned.
You're gonna have to give me a minute to find the email, sorry.
No problem.
Sorry, there were a couple of slide decks that came in this morning, so I'm trying to find the correct deck.
That sounds like a bunch of doctors getting the slide decks in late last night, early this morning.
Yes, go ahead and share, Julie, sorry.
Can you
Great,
see?
Julie.
You got it? Okay.
I can see it. I guess I'll ask you to forward them. So I thank you so much. So we can go to the next slide.
Okay, now I'm having some problems advancing it.
Of course.
Give me a minute here.
No problem. Great. So I just want to say thank you again for having me join. I really appreciate the opportunity to come and speak to everybody about kind of the subject that is most passionate to me and has kind of driven my entire career. And so I want to speak to everybody today about amputation versus limb sparing surgery and sarcoma. I'm assistant professor at UCLA. I'm the fellowship director there for orthopedic oncology. So we train one new orthopedic oncologist every year. And I'm the co-director for the bone and soft tissue tumor program at Children's Hospital as well. Next slide. I have disclosures, and these can be viewed on the American Academy of Orthopedic Surgeons website. Next slide. And so today I want to talk to everybody about the difficult decision that we have to make in every case with sarcoma, which is limb salvage versus amputation. I love relating these stories to patients of mine. And so this is a little girl who is 10 years old, or now she's 12. She had a limb salvage surgery for osteosarcoma with a growing endoprosthesis. And this is her participating back in full gymnastics, much to my dismay, but she is happy and healthy, and I'm very grateful for that. So we'll go into the historical background behind limb salvage versus amputation, general concepts of sarcoma surgery, which are going to drive a lot of this decision-making, the indications and requirements for limb salvage, some general review of some common reconstructions and their outcomes, although I want to focus less on that, and kind of some, at the end, considerations for patients and caregivers. Next slide. I think I would be remiss if I did not thank first my patients, and then also all of the folks who I had the pleasure and privilege to learn from and have helped shape my thinking on this. My current partners, Dr. Bernthal and Dr. Wessel over at UCLA, and a lot of my teachers throughout the years who have helped shape the way I think about these diseases and treat patients. Next slide. So historically, the first time we really see sarcoma published in the medical literature is by Dr. Gross, who published 165 cases back in the late 1800s. This is a famous painting of him, and he was known to be one of the fastest amputators in the world. He was not much for sterile technique. You can see doing surgery barehanded, and he advocated for amputations in these cases. We believe that most of these were osteosarcomas. Unfortunately, the outcomes at that point in time were dismal. However, because of this, amputation became the standard of treatment. At the time, survival rates were somewhere around 10 or 20%, as we had no adjuvant treatments. And so the disease outlook was horrific. Next slide. Treatment went along that way for a while until we had Sir Stanford Cade. So he practiced in Westminster in the UK, and he was an advocate for radiation therapy and would then go and amputate if there were no pulmonary metastases in 6 to 9 months. A similar approach is taken at Sloan Kettering, and survival rates were no better than they were before. And at a famous 1955 meeting in Sarcoma, he was quoted saying, if you operate, they die. If you don't operate, they die the same. The meeting should be concluded with prayers. And so this was kind of the background for what was happening in this disease, and they felt that amputation was the only real way to clear all the disease. However, without adjuvant therapies, survival really didn't improve at all. Next slide. So this was kind of the treatment paradigm. These kids would come into clinic, they'd get radiation therapy. You'd wait 4 to 6 months, and if your chest X-ray did not show any metastases, you'd go ahead and perform an amputation. And the 5-year survival rates were 21.5%. And so this was published by Dr. Cade in 1955. And so something had to change. Next slide. Finally, several centers started using chemotherapy and specifically doxorubicin-based regimens for these. And suddenly the 5-year survival rates went from 20% to 80% with kids who presented with non-metastatic disease. And so this was an enormous paradigm shift in the treatment of bone sarcoma, and that we finally found an effective systemic treatment. And with that came the growth of limb salvage surgery. Next slide. And so initially, limb salvage surgery was actually offered for patients who were refusing amputations for religious reasons. At the time, there had been some developments of custom implants made in the UK that people could order and use for these limb-sparing surgeries. For the patients that refused amputations, that's how this was started, and they started to notice that a lot of these patients did very well and were able to keep their leg. This practice suddenly, or exploded subsequently, and since about the mid-'80s, this has become the standard of practice, meaning limb salvage surgery for probably about 90% of patients, especially those with bone sarcomas in the femur, proximal tibia, and humerus. Improvements in implant design and fixation has increased our ability to perform limb salvage surgery, as has accurate and advanced imaging techniques such as MRIs that allow us to know exactly where to go and remove tumor and save the important structures of the limb. Next slide. These are 2 landmark studies in 1986 and 1992 demonstrating no difference between limb salvage and amputation in terms of overall survival for osteosarcoma, one of them out of Sloan Kettering. And so this data is really what cemented in limb salvage surgery as a reasonable option for patients with sarcoma, because we could demonstrate that we were able to save limbs and still not compromise their ability to beat the disease. Next slide. And so when we think about limb salvage, I think we still need to take a step back and put it in the context of general principles of sarcoma surgery in terms of curative surgery. So when we think about sarcoma surgery, and these are two great reviews by some friends and colleagues of mine, one for soft tissue sarcoma by Dr. Crago and Murray Brennan, who's one of the godfathers of soft tissue sarcoma surgery, and by the group at Johns Hopkins looking at orthopedic oncology specifically. But resection, the basic principles are, number one, we have to resect the whole tumor en bloc. And that means in one piece so that we're not spilling any of the tumor cells if you took it out piecemeal. The second concept is that of the margin. And what this means is we take out a layer of healthy tissue surrounding the entire tumor to try to be sure that we're not leaving any cells behind. In general, and so there are always exceptions, but in general, we believe that we really should try not to compromise the oncologic resection to help facilitate functional outcomes. Meaning, goal number one is get the tumor out en bloc with a negative margin, and then reconstruct what you have left. Next slide. So close calls, what about the margin? So margins are a hotly debated topic in sarcoma surgery. They're probably different for each tumor type that we deal with, and different depending upon what tissue the margin is at. If you're talking a margin that's at fat tissue, which is a relatively weak barrier, that's going to be a lot different than a margin at fascial tissue or cartilage, which we think is a strong barrier. People have tried to explore these concepts and research them for a long time, and we don't have perfect answers, but there is some gestalt about it. And in certain cases, we do make decisions to have a larger margin or a smaller margin, depending upon the type of tumor and where the margin is, for instance, trying to save critical structures like nerves or arteries. Another thing that this also depends upon is whether there's an effective adjuvant treatment. For instance, in soft tissue sarcoma, we know that neoadjuvant, so before surgery, or adjuvant after surgery radiation can decrease the incidence of local recurrence, meaning the tumor coming back in the tumor bed. So we use this adjuvant treatment to be able to get closer to vital structures and the tumor in order to save function and important structures. This is one of my patients who recently passed away from osteosarcoma. This is Ava. And she loved these Chinese waving cats, and so my wife got her this cat. And I think about that day all the time because it made my day. And I think whenever we do sarcoma surgery, we think about the patients that we form special bonds with. And I just wanted to highlight Ava and her journey because she was amazing. And when I do surgery and treat patients these days, I think about her a lot. Next slide. So margins for bone sarcoma. When we think about bone sarcoma, macroscopic residual disease is a problem. This requires re-resection and has poor disease outcomes overall. Microscopic residual disease is a different story and depends upon the tumor type. And I want to highlight some differences between osteosarcoma and Ewing sarcoma. Next slide. So if we look at osteosarcoma, this is a paper out of Sloan Kettering looking at outcomes for patients who had local recurrence, which they noticed at about a 4% rate over about 400 patients. Looking at outcomes of patients who had local recurrence after their osteosarcoma resection. They noticed that the thing that was most strongly correlated with local recurrence was a positive margin, and that local recurrence within the first year demonstrated for survival. Thankfully, neoadjuvant chemotherapy cut the local recurrence rate in half, but they demonstrated pretty convincingly that if you have a positive margin, you're at higher risk for local recurrence, and if you have a local recurrence in osteosarcoma, you're at higher risk for succumbing to the disease. Next slide. This is another surgery out of another study out of Florida, essentially demonstrating the same thing. They demonstrated a 14% local recurrence rate, and they found that a positive margin strongly correlated with local recurrence with a hazard ratio of 8, which is enormous. They had 75% survival at almost 4 years, and they demonstrated with a hazard ratio of over 6 that a positive margin meant you were more likely to die of disease. So we really think about in osteosarcoma, getting too close to the tumor is not a great idea, and margin status heavily correlates with people's ability to beat the disease. Next slide. And here we're looking at two graphs, both looking at local recurrence and overall survival based upon margin status. And you can see the positive margin is the green line. And so you see very, very different, both local recurrence and survival based on a positive margin in this study with osteosarcoma. Next slide. Ewing sarcoma, however, is a bit different. So this is a study looking at AEWS 0031, which is the previous large Ewing's protocol performed by the Children's Oncology Group around North America. And the difference between Ewing's and osteosarcoma is that Ewing sarcoma is sensitive to radiation, and you actually can treat the local disease definitively with radiation, surgery, or radiation plus surgery. They noticed that when looking at local treatment, radiation had a higher rate of local recurrence as opposed to surgery alone or surgery with radiation. But they noticed that local treatment and local recurrence did not seem to affect distant failure, meaning the development of metastasis. Next slide. This was a study looking particularly at Ewing sarcoma of the femur from the same overall AEWS 0031 study. And they found a local recurrence rate of 5.3% in the femur. And again, they found that local control, meaning whether the tumor recurred in the femur, did not affect overall survival. What this means is that we can treat these diseases a little bit different. And I think most of us are willing to get a little bit closer to Ewing sarcoma in order to save functional status, where osteosarcoma, I think that's a less viable option. Next slide. Soft tissue sarcoma, which I know I'm going mostly into bone sarcoma, but soft tissue sarcoma, just as important, is a very, very different group of diseases. These are some of the famous papers that have been published about radiation and margin status in soft tissue sarcoma. And in general, local recurrence is correlated with positive margins in soft tissue sarcoma, but local recurrence does not appear to affect survival. And we know that we have radiation therapy, which is an effective adjuvant. What this means is that if we have a soft tissue sarcoma that's abutting a critical structure, an artery or a nerve that's going to be critical to function, a lot of times, if we're going to do radiation preoperatively or postoperatively, we're willing to get much closer to the tumor to save that structure and save the person's function. I think what this leads to is that we have a very low rate of amputation when it comes to soft tissue sarcoma. However, there are some unique subtypes that do warrant discussion, and those would be myxofibrosarcoma and dermatofibrosarcoma protuberans. These are very infiltrative tumors, and in general, we need to get much closer, much further away from where we think the margin is, because they can seep into fascial planes and you'll get an unexpected positive margin. Next image. This is a study from 2008 demonstrating the effectiveness of radiation therapy. Next image. And this is looking at the MRI pattern of myxofibrosarcoma. And you can see there's that white tail that comes from the tumor at the top of the image that tracks all the way along the fascial plane. And this needs to be widely resected, and that's why these tumors have such a high rate of local recurrence. Next slide. So now that we've kind of gone over some of the basic principles of sarcoma surgery and some considerations regarding bone and soft tissue sarcoma, we'll bring it back to kind of the decision we have to make and ask, what is limb salvage surgery? Well, in my mind, limb salvage surgery is preservation of a limb with acceptable function after adequate removal of the tumor. And here we have the definition from the National Cancer Institute. Now, there's a lot of variability there. What is adequate removal and what is acceptable function? And these are the things that I think patients and doctors need to spend a lot of time talking out and hashing out in order to make the correct decision for everybody. Next slide. So requirements for limb salvage, and just as a picture on the side, that's one of my patients, Celia. She has metastatic osteosarcoma. She had a distal femur replacement by one of my partners. I resection of her scapula, and she has lived life to the fullest and is still doing amazing and doing all sorts of activities, even ones we may not love her to do, but really taking advantage of limb salvage surgery. And she and I follow each other on Instagram, so I get to see all the fun stuff she does, and it really makes this job meaningful and worthwhile to watch her enjoy life. And so requirements for limb salvage. We need to be able to have structural stability. The limb needs to have neurologic and vascular function. You have to have protective sensation. You want to be able to move, and the limb has to be perfused. You need to be able to have soft tissue coverage or closure, meaning you got to get the skin to heal. You need to have functional muscle groups to power the limb, so you could heal skin over bone, but if the limb can't move, it doesn't seem to be very helpful. You have to have a patient who's healthy enough to heal complex wounds or surgeries, and you have to have a patient and a family that are going to be compliant with post-operative precautions or instructions in order to allow this to heal appropriately. Next slide. So, particular requirements for the upper extremity. Thankfully, you do not have to walk on your hands, so we're able to do a lot more with the upper extremity to save hand function. You can do all sorts of larger sections around the shoulder girdle especially, and still be able to maintain meaningful hand function for life. We do think that preservation of 2 out of the 3 nerves going down to the distal hand is essential, mainly the median and ulnar nerve, because those are what drive hand function. And you can do tendon transfers or bracing for radial nerve function. Preservation of the thumb is essential, as we all think. That's what separates us from the rest of the animal kingdom. And so that's a huge part of limb salvage of the upper extremity. But thankfully, there are lots of options for tendon transfers and microvascular reconstruction if needed. Next slide. Looking on this slide, you can see, and this is kind of an interesting concept, this is a ray amputation, meaning you actually do an amputation of the entire finger as well as the metacarpal. And so this, in my mind, is both an amputation and a limb salvage surgery, because it preserves, both reasonably cosmetically, but certainly functionally, hand function. And so I think when we're thinking about these two concepts, sometimes they do blur together, and we have to kind of decide what's right for every patient. Next slide. In terms of limb salvage requirements for the hip and pelvis, you need to be able to maintain force transfer between the spine and the lower extremity, and this can be done in a lot of different ways. And the classic thought or teaching is that you must be able to preserve 2 out of 3 of these structures, meaning the hip joint, the sciatic nerve, and the femoral artery. If you're able to preserve 2 out of 3, you can reconstruct or make up for the other one with good functional results. Next slide. However, there is really good data that your femoral nerve seems to actually be more important than your sciatic nerve, because you use it to fire your quadriceps and be able to stand up straight and brace the knee. And so there have been a number of studies demonstrating that femoral nerve resection is actually more deleterious than sciatic nerve resection. Next slide. This is a good study of patients who had their sciatic nerves resected for soft tissue sarcoma. All of these patients wore braces post-operatively. They actually demonstrated that walking distance overall was unchanged, and greater than 50% maintained proprioception in the leg through branches from the femoral nerve, and were able to understand where their leg was in space. So just demonstrating that you can do a sciatic nerve resection with good function of the lower limb. Next slide. Requirements for limb salvage for the lower extremity, meaning kind of below the hip and pelvis. In my mind, it's sensation to the foot, perfusion to the foot, so blood supply, the ability to force from ground reactive forces to the pelvis, and then the ability to reasonably create limb length and have a limb length either equality or a discrepancy tolerated by the patient. Next slide. So some special considerations for bone sarcoma first. We have to think about the expected skeletal growth that's remaining and find a way to compensate that in kids who are still not skeletally mature. We have to think about joint function and potential replacement. We have to think about the soft tissue envelope and coverage. And this is very important, especially for bone, because both metal and allograft reconstructions really require immediate closure to mitigate the risk of infection. So we have to have soft tissue there to close. And then, we need to talk about the durability of reconstruction and, unfortunately, reasonable activity restrictions post-operatively based upon what the reconstruction is. Next slide. I apologize for the images on this, but I think it really illustrates well. This is a large soft tissue sarcoma that exposed the proximal humerus and the brachial plexus, so all the arteries and nerves going down to the hand. And this required immediate soft tissue reconstruction. You can't leave the nerves open like that. But special considerations for soft tissue sarcoma, again, soft tissue coverage, whether the area is going to be radiated and how that's going to heal, You can do delayed coverage or reconstruction with wound vacs now, which is becoming more popular, so that you can check the margin status before you do a, I just saw that slide. The measurements of this tumor, I believe, if you're looking at the ruler up there, that's a 15-centimeter ruler, so it's just slightly bigger. But you can do delayed wound coverage with wound vacs so that you can get the margin status back, know it's negative before you then have to go do soft tissue reconstruction. And sometimes you have to consider a potential vascular bypass. Next slide. And so this is for a distal femur osteosarcoma, the image on the left, I just pulled this up to demonstrate that there are a ton of different types of reconstruction that may be undertaken for this patient. You have a combination allograft free fibula reconstruction, a compress reconstruction, a cementless stem distal femur replacement, a growing distal femur replacement, an allograft prosthetic composite all the way on the right. And so there are a lot of different options that all carry their own risks and benefits. And this is why it's so important to have those types of discussions with your surgeon, because not one size is going to fit all. Next slide. So looking at endoprosthetic reconstruction particularly, this study is from the largest center in England, looking at 661 patients that were followed for an average of 15. Implant survivorship was 75% at 10 years. Limb salvage rate was 84% at 20 years. And there was a 34% revision rate. So while, almost, 84% of these patients were able to maintain limb length or maintain their limb at 20 years, still about 16% went on to amputation. There is a significant revision and reoperation rate. Next slide. Again, this is looking at other studies of endoprosthetic reconstruction and even things like compress, which is a unique reconstruction strategy, has about 80% survivorship at 10 years. And looking at different reconstructions in lower extremity, you can see in the graph at the bottom right, different reconstructions have different expectations. Proximal femur replacements seem to have the best survivorship, distal femur replacements the next, and then proximal tibial replacements do the worst. And allograft prosthetic composites, usually because you have so much soft tissue loss, have a lower survival rate. So each one is, they're not all the same. And we have to tailor these reconstructions to the patient's tumor, defect, and expectations. Next slide. I think about this paper every time I put an expandable prosthesis. So again, this is a study of, this is also from the largest center in England, 124 kids who were followed for at least 10 years after expandable reconstruction. And so you think about this, 91% limb salvage rate at 10 plus years. I think that's incredible. And I really commend the authors for being able to provide that type of service to so many people. However, 90% complication rate, 85% unplanned reoperation. So that while we would call this good results, almost everybody had to go through another major surgery of some type. And so still thinking about that, while we're able to perform limb salvage in the vast majority of situations, it's not without its drawbacks. Next slide. This is a biologic reconstruction, an allograft and a free fibula put together. And this one we really favor when we're able to save the growth plates on both sides of the bone for growing kids, because it allows their growth plates to keep going. And when these heal, it is unbelievable. You essentially have normal function. So this paper is looking at these reconstructions done in the tibia, this paper is done by Dr. Capana's group, the person who pioneered this. And you still look at it, 21 patients with an average 10-year follow-up, 4 failures, 83% limb salvage rate at 10 years. So still not perfect. Next slide, please. So how to choose and what is best? And this is where we get into decision-making. You have to ask first, is limb salvage possible or reasonable given the location of the tumor? We have to talk about what the expected function is after surgery, both short-term and long-term, what the complication profile is and potential for reoperation, how may this affect my systemic therapy, and what are the patient's or the family's priorities? Is it an active lifestyle? Is it looking quote unquote normal, whatever that means? These are all things that we should hash out when choosing what option is best for local control. Next slide. Now moving on to amputation. I would say in general, amputation is reserved for when limb salvage is not a reasonable option. However, this surgery option has the lowest complication rate, the lowest rate of local recurrence, and long-term similar emotional acceptance to limb salvage. And lower amputations like these below knee amputations have better prostheses and better functional outcomes. And we see people all the time doing high impact activities with these with the prostheses after these amputations. Next slide. Looking at this study, this is a recent meta-analysis from 2024, comparing quality of life outcomes between amputation and limb salvage. They were able to include 5 studies with 245 patients and examined a lot of different metrics. And while they found that in all of these metrics, limb salvage had a very slight advantage over amputation, it was not statistically significant. To me, what this indicates is that I think, we have to treat the tumor first, and patients and caregivers and all of us on the medical side, we find ways to get patients to live happy, healthy, full lives. And so I don't think an amputation is how I think most people initially view it, as a failure or as a loss, and I don't think that's the case at all. Next slide. Now there are a lot of exciting technology as well for amputation. We have osseointegration, which has been pioneered by Dr. Brannemark over in Sweden and has been around for 25 years. There is a complication profile to this, but essentially what this is you put a metal fixture into the bone, and then it has an abutment that is placed at a second surgery coming out of the bone and attaches to an external prosthesis. Patients with these are able to do more high impact activities, and they feel better force transfer because the force is actually going through the bone rather through soft tissue in a socket. And so it feels more natural and more normal. And there are a million pictures on the internet and videos of people doing very, very high level activities with these prostheses. Next slide. Sorry. Go ahead. This is a great review by one of my friends, Taylor Reef, over at Hospital for Special Surgery. And I thought this picture really brought it home. So this is a patient who has a high above knee amputation. You can see that prosthetic socket is not fitting well, and the proximal femur wants to come up and out of the soft socket. And then now once they have their osseointegrated prosthesis, the alignment of the limb is better, the force transfer is going to be better. So I think in healthy patients who can perform good hygiene, cleaning the area twice a day and being very diligent, this is a game changer for patients with amputations. Next slide. And I think this is going to be the future. So with amputation and targeted muscle reinnervation, where we take the nerves and plug them into new muscle groups in the area at the time of amputation or after, we can now fit these osseointegrated bionic prostheses. These are not ready for prime time yet, not FDA approved, but we see lots of examples like this paper of really, really amazing function with these osseointegrated prostheses combined with targeted muscle reinnervation. And I think somewhere in the next 10 or 15 years, this may be standard of practice. Next slide. And then what about rotation plasty? Hard to know whether you would call this an amputation or limb salvage. What rotation plasty is really you remove usually a distal femur or proximal tibial tumor, maintain the vessels and nerves, and then you turn it 180 degrees and reattach the tibia to the residual femur. What this does is it functionally turns the ankle joint into a new knee joint. And with a specialized prosthesis, this can be one of the most functional outcomes we have. Next slide. This was an article that was published. I had the privilege of doing this surgery for 2 9-year-old boys in the same month about a year and a half ago. And they got to kind of learn from each other and become friends, and the families became friends. And watching them go through it together was really amazing. But now both of them are walking with a prosthesis and no assistive devices, which is pretty amazing. Next slide. And so what are the benefits of rotation plasty? It grows with the patient. It's their own native tissue, and so it does not require planned revisions or lengthenings. And it's the patient's own bone. So once the bone is healed, it allows for a whole range of high impact activities. You have patients with this that play soccer, play baseball, go rock climbing. There have been collegiate swimmers with rotation plasty. So it's a really, really functional, whether you want to call it limb salvage or amputation. The drawbacks, I think, biggest thing is the appearance and emotional acceptance. And I think this is the hardest part of the discussion, and the need for regular prosthetic refitting and updates like any amputation. So when do I recommend rotation plasty? Usually these are boys age 9 and under, girls maybe 8 and under, who really have so much skeletal growth remaining that they're going to have to go through a number of large revisions before even reaching skeletal maturity of their implant. And so for them, I think rotation plasty is a better choice. Next slide. So what are the take-home points on what I want you guys to get out of this today? Understanding sarcoma surgery principles so that when you're having the discussion with the surgeon, you understand what goals need to be accomplished in surgery in order to have a good oncologic outcome. Surgery is really life salvage surgery, and so we have to think about how to make the patient cancer-free first, and then limb salvage surgery is what comes after that, and no one approach fits every patient. I think one of the biggest things for people going into this is expect to get different opinions from different surgeons. And I know that can be really scary and not make sense. But again, everybody can look at these situations a little bit differently. And there are reconstructions and options, multiple ones that can fit the same scenario. They may have different risks and benefits, but they're not wrong. And so that will happen. I think it requires a candid discussion between the patient, family, and the surgery about realistic goals, expectations, and priorities following surgery. And that many options, even amputation, can lead to really, really good functional and life outcomes. Next slide. So I think about this journey, and I want to thank a lot of my friends and colleagues and patients who I've gotten to learn from along the way. And next picture. And I want to thank my wife and my 2 kids, our family, who let me go off and do this and are really, really emotionally supportive while their dad does this job. So I want to thank you guys, everybody today, for your attention and for your care for our sarcoma community and patients, and happy to take any questions.
Thank you so much, Dr. Chris. That was amazing. Such a great topic. Okay, let's see what we have here. I'm not, okay. Dr. Chris, have you performed an osseointegration surgery for hip disarticulation amputees? If so, what are the criteria?
I personally have not done it in that scenario. If you're thinking about it really, so you can't really, osseointegration for hip disarticulation would be, I think you're thinking about if you were to have a very short residual femur, like the case that I showed. And so you're trying to avoid a hip disarticulation by doing an osseointegration prosthesis. And really the major criteria, the patient's overall health, whether we expect them to, have a low risk for infection, and then how much bone is left in the femur, and is there enough bone to fit the osseointegration prosthesis into the femur.
Okay, thank you. Okay, this one, I think, are there stats about whether limb sarcoma, so maybe are they saying, I don't know if that's osteosarcoma, spread to organs or vice versa?
So most sarcomas, as I think a lot of people on this call are probably aware, the most common place they spread to is the lungs. Bone sarcomas can spread to bone, and there are very occasional circumstances where sarcomas can spread to visceral organs. Unfortunately, that's usually pretty late stage and relatively rare.
Okay, thank you. Okay, this one. When you said there were exceptions to neoadjuvant radiation successfully treating positive margins when recurrence is close to critical structure, in this case a bone in a foot, were you referring to myxo-inflammatory fibroblastic sarcoma?
I'm just reading the
yeah, sorry, I might have butchered some of that.
So I wouldn't say that that's an exception. When we're thinking about myxo-inflammatory fibroblastic sarcoma, myxofibrosarcoma, DFSP, one of the problems is that when you look at the imaging and you see the extent of tumor, you can get microscopic disease that tracks along fascial planes further than that. And so really, those you're thinking about getting a wider margin than maybe some of the other soft tissue sarcomas you treat, because you may be leaving more cells behind that you can't see. Still, either neoadjuvant or adjuvant radiation does decrease the risk of local recurrence after that. those diseases, I think we do commonly think about taking a wider margin.
Okay. For synovial sarcoma, no metastasis, under inner side of ankle for patient wanting to remain physically active and play sports, considering the complexity of the joint, would you just recommend amputation? That may be a hard one to answer in that.
I think that's a hard one. I think you'd have to look at how close it is to some of the vital structures and whether you can get even, a 1 millimeter greater than 1 millimeter margin. The hard thing around the foot and ankle is the soft tissue coverage, and that's where things get dicey. We'll say obviously a below knee amputation would be a much more straightforward surgery and recovery, but it's also an amputation, and I really, you'd have to meet the person and really get an idea of what they were hoping to achieve long term and what risk they're willing to take to achieve that, and have a pretty in-depth discussion. I think that's one of those ones that's right on the border, and that's an individual decision for sure.
And I guess I have a little follow-up question to that. I mean, the way it's graded, so like if it were a lower grade, then you might have better options because you are taking that into consideration too, or?
Yeah, for low grade tumors, I think you're definitely willing to get closer. The risk of distant metastasis is very low, and local recurrence is not as problematic. I think most of us, if you're talking about synovial sarcoma in general, although it has a really variable behavior, I think most of us think of it as a high grade tumor.
Yeah. Okay. And then this one, I'm not sure about. Aside from TMR using meds or mirror therapies, has there been any research update on how to treat phantom pains? I don't know if you know about that, if that's your...
Better question for my wife. She's a pain management doctor, but there's a lot of different things people are trialing. It is a tough problem when it occurs. There are nerve blocks, injections, stellate ganglion blocks, all sorts of things out there. But I think, mirror therapy still seems to be one of the most effective things we have.
Okay, thank you. I think that's it. If anyone has any more questions, they can put them in the chat. And Dr. Chris, thank you so much. That was excellent.
Thank you guys for having me. I really appreciate it.
So informative, really. Thank you. Okay, I think we're going to move on to the poll, and then I think we have a break coming up. Thank you.
So we are going to leave the poll up for another few minutes just so that people can answer that. But we are at a point in our agenda where we will be pausing for a break. This is a little bit of a longer break. So I encourage everybody to grab a bite to eat, get up, move around. While we're away, we will be playing some videos from our sponsors. Feel free to post any questions in the chat that maybe come to mind, that have come to mind over the break or since a speaker ended. But we will plan to break until 3:40 Eastern time. So depending on where you are, you might have to do some time adjustments to that, but we will be back at 3:40 Eastern Time, where we will hear from Dr. Connolly at MD Anderson, and he'll be talking to us about biomarkers in sarcoma. Enjoy your break.